All right, everybody. So here we've got another routine cataract case from earlier this month. Let's see how it starts off here. We're going to make our side port. Then inject a little bit of lidocaine mixed with BSS to minimize the stinging. Really, that's why I mix it with 50-50 with BSS. Just a little bit because I don't find patients are in a lot of discomfort in general. Then a good wave of viscoelastic. Wiggle the cannula to get some of those bubbles out of there if need be. Those little small bubbles are like silicone bubbles. They're kind of annoying. 5 millimeter mark on the surface. That one doesn't look too centered, but it's okay. It's just a guideline. We make a 2.4 millimeter incision. Try to avoid making a chevron by the way you angle the blade. It does depend on if you use a single bevel or a dual bevel blade. That will change the way you make your incisions. Utrata and a 0.12 to make a capsular exis. I do try and get it as centered as possible. Try and follow the outline of the iris, keeping it equidistant from the kind of perimeter of the iris there, trying to keep it centered, trying to keep it nice and round, because at the end of the case you want good optic overlap and a centered capsular exis. I don't really appreciate when it's oval or out of round. I don't enjoy that. All right, some BSS to get a good hydrodissection and hydrodelineation, and then make sure it rotates. I like hydrodelineation for multiple reasons. I understand some surgeons don't prefer not to do that, but I'll do it almost every case when I can. A little additional viscoelastic to coat the endothelium rather, and check your phaco handpiece. And then we'll do a stop and chop, but we'll start by clearing that anterior epinucleus and cortical material to create some space. Do a little sculpting, and then this looks like it's going to be fairly easy to crack. It's not necessarily soft, but fairly easy to crack. The other reason I like to do the hydrodelineation is because it becomes very easy to see where to put the chopper, where you can put the chopper safely. And that's true when there's a significant epinucleus and also when there's a small amount of epinucleus. You can see exactly where the chopper should go. And we'll just get these last few pieces of nucleus out of there, keeping your phaco handpiece centered. A little bit of wiggling in the phaco handpiece is good. And then we'll grab the epinucleus. And you can coax that out of the capsular bag pretty easily without too much work. Sometimes you have to rotate it a little bit. And then if it's ever really difficult to get out, sometimes I'll leave whatever's remaining and get it out with the IA. The epinucleus will come up the IA handpiece. Notice also that that second instrument is always back behind the phaco handpiece, keeping the capsule back. Then we'll switch over to IA. Make sure that the sleeve is all the way down on the IA handpiece. Make sure your irrigation is working well because there may be some air bubbles in there from the change over to IA. And then we'll go around and get our cortical material. And piece by piece, I will take whatever comes. Sometimes I'll go in kind of a clockwise fashion, otherwise I take whatever comes. And I do kind of a little bit of capsular polishing sometimes with the IA if there are cortical strands there. Otherwise, I will use BSS and try and liberate any remaining strands of cortex. And also it helps to see what's in the capsular fornix irrigating with the BSS, let you know if there's any retained kind of anchored cortical pieces in the capsular fornix. And we will reinflate here with some Provisc. I'm going to use a sweeper to reduce the amount of intercapsular lens cells. This only takes, just a few seconds, and I think it reduces the amount of inflammation in the eye in the first few post-operative days. And then we will take our lens and inject it. I use a second instrument for some countertraction. Get that lens in the eye. Sometimes that leading haptic is a little bit kind of oriented in not the best direction. So use your second instrument to do that. And then I also use a Sinski to free up the trailing haptic. It's an extra step, but then I don't have to worry about whether the haptic's fully extended and how I can get that lens centered, because I do like to see the lens centered before I finish the case. Now we'll go behind the lens and get out all our viscoelastic material, get our air bubbles out, then we will sweep kind of the angle to try and get out any retained viscoelastic there. Perfect. You can see some viscoelastic up against the endothelium. Try and get that out, but don't be too aggressive. If you get out what's in the angle, a few bits of viscoelastic at the endothelial level are not going to cause too much trouble in terms of pressure. There we go. You can see the optic is nicely covered by the capsular rhexis 360 degrees. We've made sure that we don't have any retained viscoelastic. The chamber is shallow there, so we'll get our BSS in. Usually when I'm injecting BSS, I'll hydrate both the roof and the sides of the incision, and then use that stream of BSS to irrigate the angle, just to make sure there's no retained viscoelastic in the angle, and to make sure that there are no nuclear pieces that are hiding out either by the incision or somewhere in the angle, because that is annoying. And there we've got a good case. We've got some nice bleeding by both incisions, so the incisions will seal very well. And just kind of finish up and make sure everything is in the right position.